evening. At the outset, I'd like to thank Dr. Hari Prasad, Prakash, and JP sir for giving me an opportunity to speak here. My topic here actually on the brochure is pathological fractures in subtrochanteric and in children and adults. But I think the rules in pathological fractures, wherever they are, pertrochanteric or elsewhere, still are the same. And I think I would rather speak about how to the approach to pathological fractures rather than treatment as much. You all know pathological fracture is one that occurs through abnormal bone. You have bone that is not normal in biomechanical and viscoelastic properties. Etiology, big list. Especially in children, you could probably divide it 0 to 5, 5 to 10, and then the 10 to 20 years age group. But to generalize for our day-to-day practice, you could classify them as systemic, non-skeletal, non-neoplastic skeletal disease, where you have the correctable causes and the uncorrectable causes. Sort of makes it a little easier. Then you have osteomyelitis, benign bone lesions, primary malignant lesions, and metastatic lesions. Evaluation. This is when your patient actually walks into your casualty or comes to your clinic. What would you do? Initially ask history. They come with pain, so they ask for history, the nature of pain, and was the pain present before this fracture, this snapping. And the first and foremost X-ray investigation you would ask for is X-rays of the part, both the AP and lateral views, and then the evaluation. You then use your judgment after your X-rays. Then you go which path to go. Okay, this is just a basic skeleton. Your X-ray, always when you look at X-rays and you suspect that there is a pathological fracture, follow all the principles that Himakanth has alluded to. Look on the X-ray, is it immature or mature skeleton? Location, epiphysis, metaphysis, diaphysis, or so on. Zone of transition, is it narrow or wide? Zone of reaction, that is the reaction of, what is the bone actually doing to the tumor. They give you clues whether it is benign or slow growing, aggressive, or very highly malignant. You look at the matrix then, calcification sort of gives you, cartilaginous tumor or bone infarcts, and ossification, probably OGS or osteoblastoma. And ground glass appearance has been alluded to in every article so far. It's fibrous dysplasia. Look at the cortex, breached or is it intact, and periosteal reaction, and then soft tissue extension, present or not. But what Himakanth actually alluded to was he didn't use these, the last one. You look for Looser's lines, thin cortices, loss of normal trabecular bone. That you would most probably see in osteoporosis and in osteomalacia. X-ray gives you a wealth of information. Osteolytic lesions could be inactive, active, or aggressive, and you could easily see it on your X-ray. An inactive lesion, you would have the lesion surrounded by a rim of reactive bone without any periosteal reaction. In active lesions, there is an erosion of the cortex, but the periosteum is still intact. Whereas in aggressive lesions, you have large lesions that actually destroy the cortex. There is a moth-eaten pattern, and the tumor more than 5 centimeters, there is periosteal reaction. You could also see a pathological fracture there. And all your X-ray, you could also see, if there are any lesion, osteolytic, you've already seen them, they're active, inactive, or aggressive. You could also see osteoblastic lesions or a mixed pattern. Once you get your X-rays, then you go back to the basic skeleton. Where do you go? Use your judgment. Where do you go? Pathological was the age group. Do you think it is benign? Do a certain set of, follow a certain set of principles. You think it is 40 plus, then your principles again, the way you want to manage, the way you want to investigate, again becomes different. So a few examples. The first two on the left are osteolytic lesions. The one on the top right, a mixed picture. And the one on the bottom right, you have sclerotic lesions. In a workup where 40 plus and you see a pathological fracture and the primary is unknown, So this is the basic skeleton that you would want to follow. History, detailed history, weight loss, anorexia, any bleeding, clinical examination, look for lymph nodes, thyroid swelling, breast exam and PR. X-rays, we have already talked about it. Lab investigations, although they don't give you everything, they still give you some pointers. Okay, and an MRI is not just about that, say it is around the knee. It is not just the knee, it has to be the whole, a tumor study that involves the entire segment. So, and then suppose, for you suspect METs, then, the pathway is different. You do a bone scan, a CE, CT, abdomen and pelvis, CT chest, PET CT, followed by biopsy. The pathway for METs, once you do all of these, 85% of the times you actually nail the primary. And in a primary sarcoma or lymphoma, an addition of a bone scan, PET CT and CT chest, a combination of PET CT and CT chest gives you the primary or the diagnosis in about 50% of the cases. Take out CT chest, the percentage comes down to 30%. And in myeloma, apart from your skeletal survey, you would also ask for Benz-Jones proteins, serum electrophoresis and do a bone marrow biopsy. This is just the basic skeleton. The most important thing here, as Narasimha Rao sir said, fractures in children and in adults are different. Pathological fractures and normal fractures are completely different. Here, path fracture is not an emergency. Okay, the basic principles and they actually go out of the window. It has to be managed in a different way. Priority of treatment in non-neoplastic skeletal causes is treat the fracture first, and as Dr. Ved Prakash just about alluded, treat osteoporosis and so on, the correctable causes. And benign bone lesions, treat the fracture first, or at times treat both at the same time if you have access to frozen sections. Skeletal METs and in malignant lesions, it is treat the etiology first, that is get to the base of it first before you attempt a fracture, before you attempt fixation or resection. An algorithm for path fractures is almost the same, nothing different. Treatment benign causes, because we are concentrating mainly here, the peritrophantic region, has to be fixed, whether it is an UBC, ABC, what you would normally leave, a pathological fracture in the upper limb, you would want to leave it without doing anything, just put a cast, whereas in the peritrophantic region, you have to fix it with grafting and fix. For an immature skeleton, after you fix, you still use a spica, whereas in a mature skeleton, you would use a lateral buttress or an intramedullary nail. Some examples, UBC, proximal femur, and aneurysmal bone cyst. A malignant lesion in leading to a pathological fracture. This was an Ewing sarcoma in a child where the entire segment was resected and replaced with an endoprosthetic replacement. Again, path fractures secondary to METs or sarcoma. In a person aged 40 plus, a solitary bone lesion being a MET is about 500 times more common than the lesion being a primary bone sarcoma. Yet, and I point out yet, assuming METs and performing an intralesional resection can be a disaster. Okay? As I said earlier, pathological fracture is not an emergency. This is the Mirrell score. Unfortunately, many people actually talk about it, in every lesion, any osteolytic or whatever lesion they see on X-rays, they talk about this. But this scale was actually developed for metastatic lesions, okay? And anything below 7, you can go for radiation treatment and conservative. 8, the chances of fracture about 15%. Once the score is 9, the risk goes up 33%. So you do a intramedullary fixation or do fixation, but here the diagnosis has already been nailed. Okay, it has already been diagnosed. This is an example of a rhodoid sarcoma. Someone being too enthusiastic has gone ahead, pathological fracture, nailed it, plated it, and later on there was a recurrence, big swelling. It is actually an osteosarcoma. and this is a disaster. You have to replace the entire femur. So that's why it's not an emergency. You have to get to the base of it before you attempt anything. This is one from our, our own region. Osteolytic lesion. Someone went ahead, did a nail. This is what the patient landed with a year later, and this is what had to be done. A young patient, okay, someone's over-enthusiasm has actually left this patient without a limb. Treatment in bone mets, as I said, below 7, you could do radiotherapy, cryoablation, or cementoplasty. Any diaphyseal fractures, you could still do intralesional resection, do a medullary nailing, augment it with cement, and you can give radiation later on. Any pathological fractures in and around the proximal femur, neck of femur, IT, subtroch, resection and endoprosthetic replacement, whereas in subtroch you could probably do an endoprosthetic replacement or do an intramedullary nailing with augmentation with cement and then give radiation therapy. This is one of our own patients, subtroch fracture with breast, and in fact she had mets all over. One more where we've done a intercalary resection. This is a DHS, subtroch fracture augmented with PMMA. And any pathological fractures secondary to sarcoma, as in pathological fractures of the diaphysis, you could do a segmental resection and intercalary process, or a segmental resection, and you could also do extended extracorporeal radiation treatment and then plating. Use it as an allograft. And pathological fractures on the metaphyseal region, do a resection and endoprosthetic replacement. So distal femur OGS, sorry, I couldn't put up one of my proximal femur this thing because he had some other issues. Metaphyseal region, as I said, you could still go for resection and endoprosthetic replacement. Thank you.
Thank you, Dr. Himakanth. It was a difficult topic to cover in